The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
All right, welcome to the Oregon Health Authority EMS and Trauma Systems Virtual Conference. We are excited to support our EMS providers with this online platform with some CEU. So it sounds like I want to just do an audio check. Everybody's saying the sound and video is working well. That's great. Thank you. All right. I want to give a shout out to our Oregon conferences, our springtime conferences that usually take place each year. This year, due to COVID-19, they were unable to and had to cancel the conferences. But they do a lot of work in getting great speakers from around the United States. And so we took the opportunity to work with them and decided to have this virtual platform for you guys to see, get your education. And but they are going to continue next year. So I'm going to put links in the chat section if you guys want to check those conferences out. Check those conferences out and Facebook like them, follow them, and maybe attend next year. These speakers that we are having participate, some of them do attend these conferences. So just a shout out to Eastern Oregon EMS Conference, Newport EMS Conference, and the State of Jefferson EMS Conference. All right. So I am your facilitator today. My name is Stella Scott. I am the EMS and Trauma Systems Committee Coordinator for Oregon Health Authority and the Oregon CARES Coordinator. And housekeeping items for those who have not been attending these webinars today. Just a quick flyover. Attendees will get 1 hour of CEU for attending today's live presentations. You'll receive a follow-up email in 1 hour after the presentation with a link to a certificate. Please use Chrome or Firefox to open that link. If you're viewing in a group, we've created an agency roster. Have everyone sign in. You can get that in the handout section of this GoToWebinar panel. And then keep that for your records. These webinars are qualifying as live continuing education for Oregon EMS providers. They are not CAP CE accredited, and if you are viewing from out of state or out of the country, please check with your local EMS office to see if these presentations count as CEU for you. For NREMT, this might count as distributive continuing education. Please keep your certificate, the flyer for the conference, and ask NREMT if you can count these hours. If you know of anyone who has missed this webinar or any of the others and want to view it at a later date and time, the recordings will be listed on iLearn Oregon. That will be done later this week. So for those who have asked, have tried to go in and already get that content, it's not available until later. It does take some steps on our end, so we appreciate your time, your patience for that. There are 2 handouts for creating that account and viewing the webinar on the site in the handout section as well. Everyone is on mute to preserve sound quality. If you have any questions, please feel free to type them into the question box on the control panel, and we will have time for Q&A at the end. So today I'm excited to introduce Bruce Hoffman. He's going to be speaking on whatever happened to that OMI we brought in. Bruce is a critical care registered nurse and paramedic who has worked in Connecticut, Massachusetts, and Maryland. His clinical background includes the ICU, ER, trauma, cardiology, and flight. I don't know if you can put any more on there. His graduate degree is in education, and he is currently an instructor at a university in Connecticut. So welcome, Bruce. We are so excited to have you. And this is Bruce, and I will be handing over the screen to you. So.
Thank you very much, Stella. I very much appreciate it. Thank you very much for the opportunity to present today. I am speaking to you from Connecticut, which is on the East Coast. So we are on Eastern Standard Time here. It's about 4:30 in the afternoon. And I look forward to spending the next about 45 to 50 minutes with you. Whatever happened to that OMI that we brought in is essentially a story of a patient that experienced an occlusion MI, and we're going to take that story from the streets of EMS, and we're going to enter the hospital world, and we're going to see what goes on in the cardiac catheterization laboratory. This story is an actual patient that I cared for in the cath lab. The patient has fully disclosed the use of his angiogram and the pictures therefore. You will see me throughout the presentation use a pencil to kind of point different things out as we watch the various videos. Again, like Stella said, my name is Bruce Hoffman. I am current faculty at a university here in Connecticut, as well as the Chief Operations Officer with FlightBridge Ed, and my contact information is listed there. Let's go ahead and get started. So let's go beyond the streets of EMS. Before we do that, I'd like everybody to take a look at this picture. This is a grainy photo from a project that I did when I was in graduate school. And essentially what we had to do is take a word, and the word that I received was perspectives. And we had to basically find a picture that could represent the word perspectives. This was a very challenging assignment, but gladfully taking it. I kind of went on an expedition looking for a good way to graphically demonstrate the word perspectives. And what I came up with is this basically picture. So I want you guys to take maybe 5 seconds, take a look at it, see if you can pick out some of these grainy, old white and black photos and see if you can recognize any of them. And the reason that I do this assignment essentially at the start of a lot of the lectures I give is because it demonstrates that what you're going to hear from me today is based on my perspectives on the data, the research, the education, the training that I have had. So I don't know if any of you are able to pick out anybody here. Some people say King George, some people say Christopher Columbus. The answer is they're all pictures of Christopher Columbus. And one thing that everybody should find unique is that they're all wearing different clothing styles. They're all wearing different headpieces from different time periods. And yet, basically, the way that we demonstrated this is we took 12 different elementary school books from different publishers and different authors. We cut out pictures of Christopher Columbus, posted them on a piece of paper, just to demonstrate that each of those authors and publishers had their various perspectives on what Christopher Columbus looked like. So what you're going to hear from me today is my story in how we cared for this patient. Oh no, these screens are never good. So anyway, that's not a real screen, you guys. Just for those of you that are getting into presenting, if you throw up a picture like that, that usually makes a couple different people maybe experience a little bit of diarrhea, that potentially the screen just went down. But in this case, everything is actually working totally fine. So now that we have your attention, let's jump back in and let's get to the story as we journey through with this patient who had an occlusion MI and ended up being brought to the cardiac catheterization laboratory where I work. So this patient is a 70-year-old male who had just returned home from a visit from his primary care office, which was at the VA. And on the way home, he experienced a little bit of chest pressure. He was very much downplaying the symptoms as, I'm totally fine. I just, I'm driving home from my doctor's office. What on earth can go wrong here? And very much downplaying his symptoms. Essentially, what we wanted to happen is the patient had his daughter meet him at his home. The daughter kind of got him situated and settled. And what ends up happening is the daughter says, I think we should get you checked out. So they ended up activating EMS. EMS got there, essentially kind of working up this isolated chest pressure. Like I said, it was rated a 2 out of 10. Retrosternal, center of his chest, no associated other symptoms, no shortness of breath, epigastric pain, nausea, vomiting, etc. So his exam was extremely stable, and it really came down to the dad versus the daughter. And dad basically said, I want to refuse. I'm totally fine. I just came back from my primary care office. So let's go ahead and just get this done and over with, and you guys can go on your merry way. So he almost ended up being a refusal. And ultimately, the BLS crew really worked with this patient, and they ended up, transporting this patient. And so they decided to go to a local, basically a local trauma center, just a very small community hospital, not a tremendous amount of critical care or cardiovascular services, just to kind of do a, rule out this kind of mild chest pressure. And while they were en route, they started to notice some ECG changes that were very concerning, and they then opted to do a 12-lead ECG. The paramedic was now in the back of the ambulance. They ended up giving the patient 324 milligrams of aspirin, and then really just proceeded down kind of a routine ALS route with somebody that's having some very nonspecific ECG changes in association with the clinical story. And so the paramedic does a 12 lead, and BLS basically says, this guy looks really terrible. And as you can see there, you can see the patient's 12 lead ECG. You can see reciprocal changes essentially in the lateral leads, AVL, 1 in AVL, as compared to the inferior leads here in 2, 3, and AVF. And so basically the BLS provider says, wow, this guy looks really horrendous. And so they started to do serial 12 leads. They ended up diverting off to a different facility that had PCI capability. And they ended up going lights and sirens. At the time that this case happened, that was still something that was very much encouraged. Obviously, time is muscle, so we want to get them there as soon as we can. And as they were basically pulling into the PCI center, they basically the patient turned and looked at the paramedic and looked at the BLS crew and basically said kind of the dreaded words, right, that everybody in this room right now probably has heard at some point or another, and that is, I don't feel well. And with that, the patient had some pretty significant changes. You can obviously see his evolving 12 lead here. Very shortly after the patient said, I don't feel very well, they ended up going into a rhythm that is not very healthy. You can see that here on your screen. Obviously, that being some kind of torsades or ventricular fibrillation, kind of a coarse VF or torsades. And this patient obviously needed immediate care. So now the paramedics, the crews, are essentially kind of responding to this rhythm. They do, kind of immediate CPR. They barely had time to lay the patient down. I think they maybe got a couple of compressions in. They had started to put pads on that patient, right upper posterior shoulder, and basically left lower pad placement. That really works out for us in the cath lab when we receive them in terms of where our x-ray is going to work. And so they had started to put pads on the patient. There was one defibrillation with really an immediate return of that patient to what we know as an idioventricular rhythm, still demonstrating ischemia. And so this was the patient's post-arrest ECG. And at this point, they basically ran into the emergency room. And that's kind of where the time started, and that's kind of where we're now going to kind of stop and go through this case. When the patient arrived into the emergency room, typically we go right into a room and they do some post-cardiac arrest care. This patient actually regained immediate consciousness. This patient was able to converse with them, definitely said that he was still having significant amount of chest pain and pressure, no longer just a 2 out of 10. And the race starts, right? So they kind of run in, the emergency room activates the cath team. This is during the day. So the patient very much was able to basically bypass the emergency room and head right up to the cath lab, still on the EMS stretcher. However, one of the barriers when we went back and looked at this case was that the emergency room needed to register the patient. And so basically, as we pulled up to the triage desk, we gave a little bit of a tiny report and basically said, we just, if we can go, we'd like to go right to the cath lab. And it was actually one of the registration people that said we need to print out a bracelet, et cetera. And so we mitigated that, and we went right up to the cath lab. And inside the cath lab, there's typically a staff of 3 people. And so one may be like a radiology tech, and then typically associated with 2 nurses, and or a paramedic. Very often, this is one of the places that paramedics can be brought into the hospital and be extremely useful. For those of you that know, I have pretty strong stances on that I am a huge advocate for bringing paramedics and the EMS world to the inside of the house, especially during critical care transport from an intra-hospital perspective. So this case and this day, we happen to be working with a nurse paramedic like myself. We had another paramedic who was on with us, and then a radiology tech, as well as an interventional cardiologist. And so one of the benefits and one of the things that we can do in the cath lab is we have the ability to do I-stats, right? Which we can draw blood. We have an analyzer right there. And there was a couple of key pieces to the blood work that we really want before we proceed through with the patient's angiogram and eventual treatment. And one of those is to check a serum creatinine. What people know is that the serum creatinine is something that's filtered out of the blood by the kidneys. And so if your creatinine level is extremely high, that typically means that your kidneys are not working very well. When we do an angiogram, or when we look at the coronary arteries, which this patient is obviously a candidate for, we use a dye. And the dye is filtered out by the kidneys, and it's very nephrotoxic. And so in these patients that are really coming in emergently, they haven't had time to hydrate themselves, et cetera. So really getting this patient hydrated was of an immediate concern. That's done with IV fluids. And then also that we're giving them a very heavy salt or dye load. And so that really takes a knock on the kidney. So we were able to get some blood work. We were able to look at a CBC and things like that, but that does not stop us from doing the procedure. The procedure is going to continue. The only time that you might stop a procedure based on blood work is if somebody is on a blood thinner, for example, like Coumadin, right? We would want to get some blood work back. But even then, it's really dependent on the cardiologist. The EMS crew here really did a very good job. They kept the patient, like I said, right on their stretcher, brought him up to the cath lab. We drew some blood and really got that patient over to the cath table, and we started to prep the patient. And one thing that you'll often hear me chat about, in lectures like these, there are things that obviously EMS can do to help out the cath lab if you have a patient that has an occlusive MI or an acute MI that's of an occlusive nature. And so one of those things is in an acute MI, putting on defibrillator pads are actually very helpful because the patient, as we know based on data and research, that the patient's very likely can go into a variety of dysrhythmias. So when we talk about pad placement, we're looking really towards the posterior right shoulder and then the left lower side of that patient for pad placement. That works really well in terms of the X-ray and how we manipulate the X-ray inside the cath lab. The other piece is that the majority of angiograms are done on the patient's right side. And so it's very helpful to have a left-sided IV. It's not very helpful to have a right-sided IV, but certainly we can work, kind of in both cases. One question that we often get when we start the procedures is what side are we going to go in and what's the site? And so when we start talking about the site, there's a couple things. We can go in wherever there is an artery, right? And so you think about radial artery, think about brachial artery, think about femoral artery. In an acute circumstance, typically the preference is always given to the femoral, right? So down in the groin. So typically what we do is we shave a little bit of pubic hair right over where we feel the femoral vein and the femoral artery. We prep that site. And the reason we use the groin in an acute situation is because if we have to place an intra-aortic balloon pump, those cannot be placed anywhere other than inside the femoral artery. And so it's really best, even if you do an angiogram through the right or left radial artery down in the hand, it is still very beneficial to really make sure that we have the groins prepped and ready to go. And so, now the patient's on our table, essentially, we're prepping them. We gave the patient a little bit of oxygen. Certainly, we monitor end-tidal CO2. We give the patient sedation, typically Versed and fentanyl. In this case, it was 5 of Versed and 200 of fentanyl. And we went ahead, we definitely had the patient with, 1,000 liter of normal saline or lactated ringers. Either one is normal saline in this case was preferential. And then we also bolused the patient with amiodarone because of the dysrhythmia that he had and placed the patient on a little bit of Levophed. The patient was hypotensive down in the 60s to 70s, as well as his heart rate was fluctuating anywhere from 40 to 60. So we have a bradycardic, hypotensive patient who's having an inferior wall MI. When we talk about an inferior wall MI, we usually say, hey, this is likely due to the right coronary artery. That feeds really the entire inferior wall. And so that's what we're expecting. So the cardiologist in this case did a really smart thing. And ended up putting in sheaths into the venous and the arterial space. So we're working alongside the right femoral artery and the right femoral vein, and we stick sheaths in both of those arteries. I'm going to show you a video now that basically demonstrates obtaining, venous and arterial access. And so you'll see a syringe kind of come in here. We use mepivacaine to basically infiltrate that area, freeze that area up. We are feeling or palpating for the femoral artery, which lies just lateral to the femoral vein. So if you're working lateral to medial, you will notice that you first come across the nerve, which runs down along the outside of the patient's leg. And then working medially, essentially you have the artery and then the vein. You can see here right after we've numbed up the area, you can see they're going to take an open core needle and they're basically going to be doing blind insertion. They're going about 3 millimeters below the inguinal ligament and 3 centimeters above the bifurcation of the femoral artery. And they're going to go in at a 45-degree angle with an open core needle. And they're going to put the needle into the vascular space, puncture through the anterior wall, and through that needle, they're going to put a wire. And now that the wire is going in, that's going to be the guide wire so that they're not leaving metal inside the leg. They're going to pull that needle out with the guide wire now left in place. That basically acts as the railroad tracks. And over that wire, you're going to place a sheath. A sheath is nothing more than basically a giant IV with a one-way valve. You'll see there that there's a stiff dilator that they're going to pull out with the wire. And now all that's left inside the patient is just a plastic catheter with a one-way valve on it. And through this, we can insert catheters that allow us to basically go from the right femoral artery basically up and into the aorta, around the aortic arch. And remember that your coronary arteries come off just above the aortic valve. The coronary arteries come off just above the aortic valve. A couple things that we want to know. We have a bradycardic hypotensive inferior wall MI patient. We put in arterial sheath, and we put a sheath inside the right femoral vein. Because we know that the patient is having an inferior wall MI, one of the things that they are at risk for developing is bradycardia. And so before we actually did the angiogram on this patient, we basically preventatively put in a transvenous pacer, and that floats up through the right femoral vein, up the vena cava, the inferior vena cava. We float it around and we put it through the right atrium and just kind of let it sit inside the right ventricle. And so if the patient ends up becoming extremely bradycardic, we can go ahead and transvenously pace this patient during the procedure. What we're going to take a look at now is we're going to take a look at the angiogram. Again, this patient, bradycardic, hypotensive, inferior wall MI, likely culprit is the right coronary artery that comes off just above the aortic valve on the right-hand side. It literally is a tiny ostia or hole inside the aorta on the right side, and it feeds the entire inferior wall. When I go ahead and play this video, we're going to take a look at the normal vasculature first. And so here what you can see on the screen is essentially, you can see my mouse. Here is the catheter coming up around the aortic arch, and this catheter is showing up as black on X-ray because remember, the X-rays are absorbing the radiation, right? And they're producing essentially a shadow or backplate on the X-ray plate. So in this case, this is a very dull, salt-heavy, very thick contrast solution showing up as very dark. You will notice that what we don't see is essentially any dye or any coronary arteries. And that's because we're going to be able to see them when we inject dye down the coronary arteries. And there you see it. You see the dye going in and down the coronary arteries. So what I want to show you next is essentially a picture of the right and left coronary arteries. This is the left coronary artery. We typically take a look at the left coronary arterial system multiple times, meaning the heart is a three-dimensional object, but we are using two-dimensional technology to see it. So what we need to do is be able to rotate that X-ray around the patient to be able to get a look at the front, the backside, and the side of all of these coronary arteries. And so here's another picture of that left side filling that entire system. And so if I back up the video right here, what I'm pointing out and what I'd like to point out is this. This right here is the left main coronary artery. When people have a blockage right here, that's called a widowmaker. Then you have, this is the circumflex artery that comes down. This is a marginal branch that comes off. Then you will see coming down the anterior surface, that's the left anterior descending with a couple of diagonal branches coming off of it. Why this becomes important is because what we know is that the culprit in this patient is likely the right coronary artery. So what we do is we take pictures of the left coronary artery first. A lot of people will ask, well, how do you know what you're looking at? So wherever you see these like little dark spots here, a lot of people say, oh, those are blockages. Those aren't blockages. That's just where the dye is overlapping. And so it appears darker. What a blockage would look like, if you had a big old chunk of calcium sitting right here, you would see a narrowing as the dye tries to go through that, okay? So that's essentially what you're looking for on an angiogram. So that's the left coronary artery. The diagnostic angiogram literally takes less than 5 minutes, okay? So here you see that the dye is being injected down the coronary artery. One of the things that we want to know is that as you're injecting dye down the vessel, you are also displacing blood, right? Nutrients and oxygen from the myocardium. So it's very common to actually have some ST changes as you're doing a diagnostic angiogram. So there we have some pictures. So now let's take a look at the right coronary artery. The right coronary artery is shaped like a C. You can see here the spine. You can see the catheter coming down. And here's the catheter tip right there. We're going to inject dye down the coronary artery. It bifurcates into the PDA and the PLV branches. Let's take a look at that again. So that is the catheter buried down the coronary artery. You can see right here the AV groove branch. And then you have the PDA and the PLV branches, which go over and feed the entire inferior wall. This is a right dominant patient. 90% of the population are right dominant, which give rise to the PDA vessel, or the posterior of the right coronary artery, feeding that inferior wall. In 10% of patients, you'll typically see them be left dominant, where the circumflex or the marginal branches give rise to that posterior descending artery. So that's the right coronary artery. Now, remember we said it's two-dimensional. So let's take another look at the right coronary artery. There we see it in one view. Let's take a look at the next view. This is giving us a view of the back of the RCA. Again, three-dimensional object. And you can see as that dye moves down the vessel, remember your coronary arteries fill during diastole. So as you experience diastole, it pulls blood down the coronary artery, and you will see it blush into the myocardium. And you can see that all down here with these hair-like projections or small arterioles as they bleed into the myocardium. So in this patient, that is obviously not the case, right? This angiogram that we saw here is of a normal patient. So let's take a look at what this guy's right coronary artery looked like. So remember, he had a normal left-sided system. This is the angiogram. When we put the catheter in on this patient, this is what we saw for the right coronary artery. So you can see it's a very quick film, but what you'll notice is that the catheter comes down. You can see the proximal RCA. You can see the AV groove branch come off, which feeds the AV valve, or the AV node, excuse me. And you can see that we are completely obstructed here. This is a 100% occlusion. That means that there is no blood flow getting to that inferior wall, okay? So that's the picture that we saw. Short and sweet, not a lot to sit around and look at, right? So now let's take a look at what happens. Because there's a blockage, we need to put a wire down that vessel, and over that wire, we need to put a balloon and then eventually a stent, and we need to open up that artery. So what you can see here, and I'll play this video in a moment, this is normal or healthy endothelial tissue that lines the blood vessels, okay? And what you'll notice is that there's been some fatty deposits up here. And there's almost been a capsule that has formed over this atherosclerotic plaque. But what you will notice is that there's a substantial narrowing in this area. And so that's what you're going to see on the angiogram, is this substantial narrowing. In this case, this patient has no blood supply. Now, a lot of people think that a myocardial infarction is caused by these types of blockages, when these basically just grow to be 100%. And that is not the case. The majority that happens is right here, when you have this nice smooth layer, but then you get like a little chip taken out of it, right? For whatever reason. This exposes this atherosclerotic plaque and buildup. It breaks the capsule. And now that this area attracts inflammation. So the body develops basically a pro-inflammatory response. And what comes with that? Cytokines, you have platelets aggregating, and basically all of that stuff gets clogged up in this area. So we need to go through, and we need to not only put a wire to get rid of all that stuff, but we also want to make sure that we crack the plaque and smush this plaque up against that endothelial wall. And so that's what I'm going to show you a video of right now. You will see a wire being passed down. There's the wire and there's the balloon. You'll see the balloon that's inflated with heparinized saline and dye. We inflate that balloon, push that plaque up and against the arterial wall. We restore blood flow. Here comes the wire, and we're going to inflate a stent. A stent is nothing more than, it typically ranges from 2.5 millimeters up to 5 millimeters. We completely expand that stent, deflate the balloon, pull the balloon and wire out. That stent stays in. And that's how we establish and maintain reperfusion. A couple of things that I'd like to point out here. In this video, right towards the end, when the stent stays in, one of the things that you will notice is that this stent is now exposed to the blood, and the body believes that it is a foreign object. And so what does the body do to that? It starts to attack it. And that is one of the reasons why patients are put on anti-inflammatories, namely aspirin and something called Plavix or clopidogrel. There's also several others like Brilinta and things like that that allow to kind of kill that inflammatory response and also keep that blood very well anticoagulated. So that's essentially the procedure. Okay, so let's now take a look. Here's the wire that's gone down the right coronary artery. And you can also see that this is after the patient has been ballooned. So we've already put a balloon down and we've pulled the balloon out, but we leave the wire in. So what we're going to do now is we're going to inject a little bit of dye down that right coronary artery. And what you can see is that we've established flow. One of the things that I want to point out here is this. You will notice that basically these areas on this angiogram from right here to like right here, it's very hazy looking, right? That's because there's a lot of thrombus and clot. Whereas now down here, this artery is nice and smooth, right? So it was essentially, this was causing the problem, but it was obstructing flow to the distal myocardium, okay? So what we're gonna do now is we're gonna put in a stent. We're gonna put in a stent and we're going to try to maintain patency of that blood vessel, okay? So that's the angioplasty, okay? So now here's the stent. The stent has little markers on it, and we fill the stent with dye. There's little markers on each end, so we know exactly where to put it. It's a very precise, very particular procedure. And as we inflate the balloon inflates the stent. It's almost like chicken wire. And then we deflate the balloon, pull the balloon out and the wire, and now the stent stays in. So here's something to think about. While this balloon is being inflated, we are essentially maintaining an embolus, or in this case, it'd be a thrombus here. So we are obstructing blood flow. So very frequently, one of the reasons that we don't sedate people in or put people under general anesthesia for a cardiac cath, as many people want to because they don't want to remember it, it's because we want to ask the person if they're having chest pain when we are working on their artery. If they are, that's a pretty good guesstimate to say, is that the pain you experience? If it is, then you pretty much know that that's the culprit, outside of some of the other obvious findings and signs. But we want to be able to wake the patient up and talk to them. So we're inflating this balloon. The stent has expanded. It's being pushed into that endothelium. And it's a very, very quick picture that we take. And so it just basically shows the stent and the balloon being inflated there. So that is what you see. Now we're going to take a look at what it looks like after the stent has been deployed, the little piece of chicken wire. In this case, it was a 3.0 millimeter by 24 millimeter stent. And you can almost see it if you take a look. The stent is right about there. So 3.0 millimeter by 24 millimeter. And so here we have expanded the stent, and now you can breathe a big sigh of relief because we have successfully helped our patient. And so let's take a look at this as we have established blood flow. And you can see there that there is nice blood flow throughout that entire vessel, okay? Very good. All right. So now one thing that I want to show you. So now that the stent has been deployed, we've reestablished, we have reperfusion. Awesome. Now we do what's called a ventriculogram. So it's a picture of the left ventricle. So this is the catheter. It's called a pigtail catheter because we want it coiled up. We don't want it to stick into the edges of the left ventricle. And the ventricle is kind of shaped like this. And we're going to be able to see the inferior wall down here. We're going to be able to see the apical wall down here. You'll see a little bit of the lateral wall here, higher lateral wall up here, and then the anterior wall here. And so what we're going to look is we're going to inject a bunch of dye inside the cavern of the left ventricle and watch it pull or push blood through the aortic valve and into the aorta. Because this person had an inferior wall MI, meaning that the heart was starved of blood, nutrients, and oxygen to the inferior wall for a few moments of time, this wall down here, this inferior wall, probably is not going to be working as well as it should be. So let's go ahead and take a look at this patient's heart as we inject blood throughout the left ventricle. And there you can see it, the bottom wall there, you can see that it's way more sluggish, right? It's way more sluggish than the rest of the heart. So look at the bottom portion of the screen. So what you're looking for is this right here. This is the inferior wall, apical wall, lateral walls, and then also the anterior wall. These walls are moving perfect. This wall down here, it's a little what we call dyskinetic. It's a little dyskinetic. And that means, and that basically will tell us that we have found the culprit and that we now need to rest and recover that inferior wall or that left ventricle. All right, so that's a ventriculogram. So I can probably already hear if Tyler Christofoli is on, he's probably saying, hey, can we see that by echo? And absolutely, you could see that by echo. And very frequently for patients that are not cardiac catheterization candidates, a lot of times if they're having like an occlusive MI or a non-occlusive MI, they'll very frequently do an echo to determine if there is abnormalities within the ventricular wall. So that's the procedure, right? Lo and behold, we've gone through it. We've spent the last 50 minutes talking about this case. We just have a couple more things to get through. And now we're going to take a look at how we allowed the patient's ventricle to rest and recover. And that was through the insertion of an intra-aortic balloon pump. An intra-aortic balloon pump is a literal pump that is placed. It's a balloon catheter that's mounted essentially on a slim catheter that goes up the descending aorta and basically sits just below the takeoff of the subclavian artery on the left side and just above the renal arteries. And this balloon, it's a literal balloon, it fills with helium, anywhere from 30 to 50 mLs of helium. And it works on the theory of something called counter pulsation. Basically, when the heart is under systole or contraction, the balloon is deflated. And when the heart is under basically relaxation, right? Relaxation, the balloon is inflated. Well, guess what? We know two things to preserve the myocardium. We want to, one, increase the coronary perfusion pressure, which if we increase the patient's diastolic pressure, which is when the coronary arteries fill with blood, lo and behold, we are going to increase diastolic filling pressure. We're going to increase coronary artery perfusion pressure. We're going to get better filling of those coronary arteries. That happens during the balloon inflating, which is when the heart is relaxing. Then when the heart is under systole or contracting, the balloon deflates, and that creates a big potential space here, right? All that area right there was filled up with a balloon. Now that balloon is deflated, the heart can go under contraction or under systole, and it's pushing against a lower pressure environment. So we have essentially done two things. We've increased coronary perfusion pressure, and we have reduced something we call afterload. Those are two keys to allowing a myocardium to rest and recover, which is exactly what this patient needed. To be able to see this, I'm going to play this video. You can see the balloon inflating and deflating, and look as it slows down. The balloon inflates, putting back pressure on the coronary arteries during diastole. Then during systole, as the heart contracts, you can see the balloon deflating, basically creating the Venturi effect or a vacuum and pulling blood into that potential space, reducing afterload. And that's how we were able to allow that myocardium to rest and recover. We now take a look at the culprit. The culprit here was that little piece of thrombus that you see on my finger. Essentially, what happened to this patient was a right coronary artery occlusion that basically ended up looking like this, filled up with a bunch of thrombus when it should have been looking like this. So that patient had a 100% occluded right coronary artery, and after we put the stent in, they now had a 0% occlusion of that right coronary artery, allowing for near perfect perfusion into and down the myocardium. What was the patient's outcome? Patient spent a day in cardiac ICU, was weaned off of the balloon pump very quickly. He went to step down for 2 days because he had an MI. Obviously, we want to teach him about things like heart failure, which he's going to have as he rests and recovers his myocardium. We do a lot of teaching up there. We also look for dysrhythmias. We make sure that he has been fully anticoagulated and basically anti-inflamed, right? Because we don't want that stent to reocclude. And then he was discharged home in stable condition. What's the future going forward? The future here is Dr. Scott Weingart, Dr. Stephen Smith, renowned paramedic Andrew Merleman, and several others have written about something that is called the OMI Manifesto. And it basically is talking about how STEMI, the term STEMI, can be very misleading. And that all STEMIs, we had all the STEMI mimickers, right? Pericarditis, left ventricular hypertrophy, pacing, et cetera. And what they're really saying is that takes away from our ability to say, what we really want to know, is this patient having an acute coronary occlusion? Is it an occlusion MI or is it a non-occlusion MI? And so I would leave you with these parting words, and this parting suggestion is that you take a look at the OMI Manifesto and see how you can best implement it into your practice as we continue to provide the best patient care possible we can to those that we serve. My name is Bruce Hoffman. Again, the Chief Operations Officer with FlightBridge Ed. You can see my contact information there on the screen. I very much appreciate your time and attention today, and I'll be very happy to stick around and answer any questions. At this point, I would turn it back over to Stella. Thank you all very much.
Thank you, Bruce. That was amazing. I am so excited that we were able to get you here and being able to talk about this. I think this helps a lot of our providers, especially in our rural areas that may not have the opportunity to see this. So we do have questions, and I will go ahead and start. So what are your thoughts on EMS use of iStats?
I love the idea. I think in the environment that we stand right now, it's probably not totally cost effective or even cost able. But I think as we kind of move towards the future of mobile integrated healthcare and really being able to work with the hospital systems, I very much see iStats becoming a part of what EMS does regularly. So I love the question, and I certainly hope that EMS can trend in that direction. From the critical care side of the house, absolutely. We are already using them, and they are super helpful in cases like this. Great question. I certainly hope to see it become a standard of care at some point in the future.
All right. What are your thoughts on nitro drip use, pending BP and inferior involvement in acute MI and rural EMS? The closest PCI capabilities are 1.5 to 2 hours away, 30 to 40 minutes flight, not including the scene time.
So that's another very good question. That is a very hot topic. You're going to hear a variety of opinions on it. The literature is not completely clear. What we do know is that nitro causes vasodilation, which will very nicely kind of allow for the anticipated relaxation of those coronary arteries, allowing for better blood flow. We also know that as you relax those coronary arteries and you allow for more blood flow, you're going to eliminate certainly the pain that is associated with that. What I would really caution folks here is that where the whole nitro and inferior wall thing really came in was with long-lasting nitrates. So, for example, you have a patient who's on isosorbide or Imdor that's taking nitrates orally. That's really where if somebody had a significant inferior wall MI where they really knocked out their complete right ventricle, that putting them on long-term nitrates may not be the best solution, certainly as they recover and rest their inferior wall. In the acute setting, I think it's very much arguable. I think we're starting to see either nitro drips or even nitroglycerin IV push, to be able to treat certain conditions. So I would definitely stay current on the literature. I do want to leave you with one thought is this. As much as you can give nitroglycerin to cause vasodilation, remember that it also causes an overall drop in the patient's diastolic blood pressure. And remember that your coronary arteries fill during diastole. So if anything, I have a little bit of greater concern for the person that is having maybe a non-occlusive MI, what we used to call like a non-ST elevation MI, that has coronary artery disease, but is not becoming a problem in terms of they're not under active injury at the time. When you give that person nitroglycerin, you are literally vasodilating them, reducing their diastolic blood pressure, therefore reducing their overall coronary perfusion pressure. So that's kind of how I would answer that question, is really twofold. Do I think that it's safe to administer nitroglycerin in an inferior wall MI with true RV, RV involvement? Yes. Do a right-sided 12 lead. You can put the patient on a regular 12 lead, literally pop V4 off on the left side, put it on V4 on the right side, hit print again. You can really look at that right ventricular wall to see if it is actually injurious or ischemic. And then certainly giving your patient a little bit of fluid before you give them nitro. Those are all ways to kind of go about and think about that application. So I hope that answers the question, and I appreciate the question.
What are your thoughts on Brilinta use in EMS for STEMIs?
So I like it. There are several places that are currently doing it. I don't know that we have a tremendous amount of data yet that tells us exactly about the outcomes. But from the presumptive data, what we have seen so far is that it is helpful, right? They haven't really found a tremendous amount of reasons not to do it. But I would ask whoever, put in that question to really stay on top of what the literature is showing. And if you know of a service that is doing it, ask them for their hard numbers and values to see what they're seeing.
Great. When you mentioned the stent being attacked by the body, is that what a large part of the stent failures is related to?
Yeah, that's a very good question, and absolutely it is. It's typically, so for example, you have a patient who may be syncopized at home because they became bradycardic and hypotensive. That person maybe ended up developing, or had a hip fracture because they syncopized and fell. So the patient comes in having an inferior wall MI, they stent that patient, and now they keep them in the hospital because they'd like to put that, they need to do a revision on that hip. And so, the orthopedist and whoever comes in and they say, hey, the patient's on Plavix, right? They've only been on Plavix for like 2 or 3 days. They say, let's stop that Plavix before we take that person to orthopedic surgery. They certainly stop that patient's Plavix, and then literally less than 6 to 8, maybe even 12 hours later, they're developing another MI because the body went to attack that stent, it clotted off, and now you have a stent failure.
Are there some reasons why patients get drug-eluting stents and others don't?
So drug-eluting stents and bare metal stents is kind of how they're differentiating them. It's really with comorbidities, such things like diabetes, right, or other metabolic diseases where they might consider putting in a bare metal stent instead of a drug-eluting stent. Most people are candidates for drug-eluting stents. There's plenty out there, and they're continuously evolving and improving the drug that is coated on that stent. And so hopefully we'll continue to see very good progression in that area.
All right. So are there circumstances when an axial flow device is preferred over an IABP?
So that's a really good question. So he's probably the person that's asking about that is likely talking about maybe even like you might have a Impella device or something called the New Pulse, which is like kind of a portable intra-aortic balloon pump. It sounds like that person's directly referring to maybe like an RVAD or an Impella or even a specific type of LVAD. In the short term, they're probably always going to put in a balloon pump. patients that are not candidates for balloon pumps, primary reason is that they have significant aortic valvular disease. And so if the aortic valve is suprastenotic or calcified and does not open and close all the way, when you inflate that balloon inside the central aorta and you put back pressure against an incompetent aortic valve, you actually end up filling the left ventricle with blood. That raises the left ventricular end diastolic volume, which limits the amount of blood that the left ventricle can receive from the left atrium, and you end up putting that person into a low outflow state. And so, yes, there are times where they will put that patient directly, with an Impella device or some kind of mechanical circulatory device like an axial flow device. But in the short term, likely you're probably always going to see the balloon pump unless some of those contraindications that we just talked about.
All right, we have a couple more here. If someone has a ventricular pacemaker, why would a monitor call STEMI who has a left BBB?
Yep, so that's where we look at something called Scarbosa's criteria and the modified Scarbosa's criteria. A lot of the pacemakers now actually are not causing this because they're implantable. Something called like the micro device is implanted directly into the left ventricle, and it paces directly from inside the left ventricular cavern, so they're allowed to use very low outputs of electricity. But some of the older pacemakers, as you see